Assalamualaikum and good morning. Welcome to the next National Institute of Health Continuous Medical Education Session 2024, organized and brought to you once again by Sector for Research Information Resources, NIH. We are now live from our NIH studio in Setia Alam and also via our YouTube channel, NIH Malaysia, Ministry of Health Malaysia. Alright, so today we have another series of CME, and this is a platform where NIH researchers trying to share their research findings, experience and knowledge to the public. Okay, so together with us today, I have a very special guest on board. My name is Nurul, Syarbani, Eliana. I'm your moderator for today, and our guest is Dr. Nurul, Jihan, Noris. But before we proceed, take a look at this promotional video.
The healthcare industry is continually evolving, which poses new challenges in the world today. The need for health management arises with advancing technological innovations, changes in healthcare regulations, and ever-rising patient expectations. Marking its success since its humble beginning in 2000, the Institute for Health Management is part of a remarkable journey that many can attest to. We are committed to being a research and training hub, as well as providing invaluable consultancies to fulfill health management needs in delivering and managing quality healthcare in Malaysia. Throughout the years, our evidence-based health management researchers strengthen decision-making and facilitate vital policy formulation and implementation throughout the Ministry of Health. Since 2006, we have conducted over 650 courses and have empowered over 30,000 individuals. Our goal is to guide you to grow into your full potential and to maximize your performance. We impart the relevant knowledge, technical skills, and organizational mindset to healthcare managers through consultancies, leading the way to achieve a transformed healthcare system. We are comprised of 3 centers, which are the Center for Leadership and Professional Development, the Center for Organizational Excellence Development, and the Center for Clinical Governance Development. Our talent grooming program, TGP, enriches the process of building leadership capability and inculcate other qualities among potential technical healthcare professionals. We take pride in producing innovation by developing TGP and MyTGP, which officially became intellectual properties of the Ministry of Health. Our initiatives in research in optimizing hospital services and issues of overcrowding led to the innovation of Cluster Hospital. Cluster Hospital is a concept where all nearby government hospitals share and expand their medical resources, services, and expertise. We have been involved in the training, implementation, and evaluation of cluster hospital initiatives since 2012. Lean thinking is about eliminating waste in work processes and optimizing available resources. It was introduced as part of the government's effort to improve efficiency and tackle issues of overcrowding in public hospitals. IHM is the Lean Center of Excellence for research, training, and consultancy in the Ministry of Health. We take pride in our involvement in associated research projects set off a ripple effect where it has been translated into policy and implemented into the Malaysian healthcare system. Over the years, we have fostered partnerships with numerous local and international agencies. Our mutual aim is to promote and support excellence in healthcare by building collaborations. We grow in strength, in line with a vision of striving towards the center of excellence in health management. The Institute for Health Management, or IHM. Better solution through research.
Welcome back. For those who just joined us, you can always do register yourself at the link provided in the description section, or should you have any questions or comments, suggestions to be made, you can always key in your questions also in the link provided in the description section. Don't forget to subscribe to our channel to catch us on our latest update later. All right, so can we start?
Yes.
Okay, let me give you a brief introduction about our speaker for today. Together with me, like I said before, I have Dr. Jihan Noris. She is currently the medical officer from the Center of Organizational Excellence Development, Co-Ed, Institute for Health Management, IHM, National Institute of Health, Ministry of Health Malaysia. She obtained her Bachelor of Medicine and Bachelor of Surgery MBBS in 2009 from International Islamic University of Malaysia, IIUM, starting her career as a houseman in Hospital Kuala Lumpur in 2009. She was then moved to Klinik Kesihatan Hiliran, Kuala Terengganu as a medical officer for a year before went back to Klang Valley and served patients in HKL and Hospital Banting. I did a bit of background search on you.
Yeah.
So in NIH, since 2019, she joined Institute for Health Management and has conducted research on health service delivery, including action research, cluster hospitals, lean healthcare, and most recently, hospital overcrowding. Aside from research, she has been a trainer for action research since 2019. Her area of interest include health service delivery, health management, health system, to name a few. She is also previously was a trainer for Lean Healthcare Initiative. She was not only active as a trainer in specific research area, but she's also actively published numerous scientific reports and publications such as My Lean Awareness Module, Technical Report on Lean Healthcare Initiatives, Action Research E-Module, Exploring Implementation Boosters of Cluster Hospital Initiative among Allied Health Professionals, and Qualitative Evaluation of Cluster Hospital Implementations, Patients and Healthcare Providers Perspective. She is also the author of many articles published in peer-reviewed journals and had presented her papers in various conferences locally and internationally. So if I were going to read the long list, I'm afraid we won't have enough time for this CME session. So into this session, she comes as the principal investigator for her project entitled Understanding the Role of Diabetes Educators and Measuring Their Time Spent for Diabetes Care in Ministry of Health Primary Health Clinics, Negeri, Sembilan. So hi doctor, how are you?
Hi.
Feeling good or feeling nervous?
Yes, I'm feeling fine.
Feeling fine, okay.
And nervous a bit.
Okay, had your breakfast?
Yes, thank you.
Because we need our stomach to be full before our brain can function very well.
Yes, agree.
Yes. Okay, so if you are ready, without further ado, I would like to invite you on board to share your research findings.
Okay.
All right.
Okay, thank you very much. Assalamualaikum and good morning everyone. Thank you Miss Eliana for the very long introduction, and thank you also to NIH Library for the opportunity to present my research findings. Okay, without further ado, I would like to start my presentation now. This is the title of my presentation. The project is titled Understanding the Role of Diabetes Educators and Measuring Their Time Spent for Diabetes Care in Ministry of Health Primary Health Clinics, Negeri Sembilan. These are the list of investigators with myself as the lead investigator for this project. These are our stakeholders were Disease Control Division in Ministry of Health Malaysia and also Unit Kawalan Penyakit Tidak Berjangkit or NCD unit in JKN Negeri Sembilan. So this is the content of my presentation today. As you are probably aware, Malaysia is facing a growing public health concern where there is a rising prevalence in Malaysia year by year, as evidenced from this graph. From NHMS 2019, when you see Negeri Sembilan recorded the highest prevalence of diabetes mellitus among Malaysian adults. 68.2% of these patients seek treatment primarily at PHCs, or also known as Klinik Kesihatan. The rising cases of diabetes, as you can see here, puts a huge burden on our healthcare system. Thus, a more holistic approach is needed to manage this patient and also the complications that comes with it. Traditionally, diabetes patients are treated more to provider directed, whereby the patient complain to the doctors and then the doctors will prescribe medications and start surgical interventions when complications sets in. But lesser emphasis was being put on educating the patient and guiding them towards behavior change. Looking at these issues that we have right now in Malaysia, it's about time that we put more emphasis on guiding the patients toward becoming self-manager of their own diseases and possibly to delay the progression of their disease. This is usually being given by a trained personnel, namely the diabetes educator or DE. So who is DE? Diabetes educators are healthcare professionals whose practice focuses on educating individuals with and at risk for diabetes to become effective self-managers. And they play an important role to equip patients with the knowledge and confidence to achieve self-care goals for metabolic control. In MOH Malaysia, DE are Assistant Medical Officer, AMO, and nurses who completed either post-basic certificate in diabetes management or advanced diploma in diabetes care. So why the importance of this study? DEs are labelled as essential in diabetes care, but they themselves were unaware or unclear on how to carry their roles. Based on a study on DE by SAIDI, one of the contributing factor was the insufficient guidelines on DE's role in PHCs, which led to multiple interpretation of their role and multiple task execution. And as I've mentioned earlier, they are AMO and nurses by profession. So they sometimes face conflict on which role to prioritize, whether the role of the nurse or AMO or the role of DE. In addition to that, they also encountered challenges from patient, team members in the clinic and organisation, which affect the optimal time that they were able to spend for diabetes care. We know that the issue of DE not having enough time is here in Malaysia, but to our knowledge, there is not yet literature to document the actual time on the DE. So this study intends to measure the time they actually were able to spend for diabetes care and also other activities required of them. And we also identified what are the factors affecting the time spent. So with that, our research questions were 3. Number 1, what are the roles of DE for diabetes care in PHCs? Number 2, how much time they spend in performing diabetes care? And number 3, what are the barriers and facilitators affecting the time spent? So our general objective is to understand the role and then to measure utilization of time in PHCs Negeri Sembilan, and finally to explore barriers and facilitators affecting the time spent for diabetes care. So going to methodology, this figure shows the summary of our phases. Our study was mixed method study conducted in 3 phases. As you can see here, phase 1 was a qualitative study to answer the RQ number 1, what are the roles of diabetes educator in PHC. Following that, we conducted a quantitative study, a time motion study, to measure how much time they spend in performing diabetes care. And then phase 3 is a qualitative study to answer RQ number 3, what are the barriers and facilitators affecting the time spent. So I'll explain the phases in the next slide. For phase 1, we started our study by conducting document reviews on available modules, guidelines, articles on DE's function. And then we formulated a semi-structured guide to conduct in-depth interviews to diabetes educators and also representative from divisions in MOH such as nursing, cawangan pembantu pegawai perubatan and bahagian pengurusan latihan. And the findings were analysed by content analysis. The output from the first phase was taxonomy of these activities and listing our findings from content, from document reviews and in-depth interviews. And also we developed an observation sheet to be used in phase 2. And then in phase 2, we conducted a pilot study first. The objective of the pilot study to 3 PHCs in non-sample clinics outside of Negeri Sembilan was to test the tool that we developed and also to capture whatever activities that were not captured in phase 1 and to familiarize our research team members who are mostly not from clinical setting about the ways in the clinic and also to familiarize them with the tool use. After the pilot study, we conducted a time motion study employing a direct observational approach, direct continuous observation for 5 consecutive working days. 1 observer shadowed 1 diabetes educator for 5 days from the start of the working day until the end of the working day. During the observation, the observer will record each task, the start and the end, and the detailed description of each activities. The findings were analysed descriptively. From phase 2, the output was taxonomy of DE's activities, upgraded from the first one, and then time spent for DE's activities in PHCs. Lastly, we conducted, in phase 3, we conducted IDIs and FGDs to 27 diabetes educators who were purposefully sampled based on the proportion of time they spend for diabetes care analysis finding from phase 2. And then years of experience as DE and their profession. So the findings were analysed thematically and the output was barriers and facilitators list for DE in PHCs. Okay, so that is for the methodology and I will present the result by phases. First, for phase 1, what we captured during the phase 1, the key role of a DE is as an integral member of a multidisciplinary team approach in PHC. The other roles are to conduct patient assessment, examination and screening, to customize counselling based on patient's disease stage, provide group education and involve in diabetes-related program both at clinic and community, and finally to manage NDR for the clinic. NDR, for those who do not know, is a web-based data collection system established to monitor the clinical outcomes of diabetes patients at the PHCs. So our content analysis findings yield 5 major domains of DE activities, which were diabetes care, non-diabetes care, administrative, supportive and personal. Diabetes care here refers to the direct and indirect care to patients diagnosed with diabetes mellitus. For non-diabetes care, direct and indirect care to other NCD patients such as hypertensive, high cholesterol, outpatient duty and community engagement. For this presentation, I will just focus on the two domains here, diabetes care and non-diabetes care. So, zooming into the diabetes care and non-diabetes care, we further analyze it into subdomains. We further categorize it into direct and indirect care for both of the domains. For direct care within the diabetes care includes counselling, giving treatment to patients, self-care, monitoring and screening. For indirect care, patient documentation, update NDR, professional development. Professional development here means attending courses related to diabetes. For non-diabetes care, other than segregation into direct and indirect care, we also noted that they spend a lot of time for NCD patients. So that's why we further divide it into NCD and non-NCD. Direct care NCD includes physical exam, group counselling, while for non-NCD includes triage, ambulance call and so on. For phase 2, how much time was spent by DE in performing diabetes care? This is the socio-demographic characteristics of the DEs. Most of the DEs were female, aged between 31 to 40, and majority of them were Malays. And most of them, 88% of them were nurses with the qualification of post-basic certificate in diabetes management. Majority of them had 3 to 7 years experience as DE, and 39% of them came from clinic type 3. Interesting to note here, in Negeri Sembilan, they have clinic type 1 until type 6, and each of these clinic has their own diabetes educator. So our observation was for 5 working days. So the estimated baseline total is 2,790 per DE. But this could be longer as some of the DEs extend their time in order to complete their tasks. So we analyze the time by domains. The total, out of this total, sorry for the mistake. Out of this total, 68.9% spend most of their time for diabetes care, followed by non-diabetes care. So, moving into the diabetes care subdomains, we further analyze it into the direct and indirect care. So, out of that 68.2%, interestingly, most of the time spent was for indirect care as compared to direct care. And if you can see here, most notably is for patient documentation, 37.4%. This is also evident from our interviews where the DEs highlighted that the heavy amount of documentation led them to spend more on documentation rather than for patient counselling. If you can see here, patient counselling only 12.5%. Okay, for the non-diabetes care, out of this total, 44.6% were devoted for direct care non-NCD, such as ambulance call, working at the procedure room, triaging, administer vaccine, followed by the direct care non-NCD. This is also echoed from the interviews where the DEs highlighted that they need to prioritize the regular nurse punya role, such as the triaging, administer vaccine. That's why the proportion is more for the non-NCD. For result in phase 3, what are the barriers and facilitators? The bulk of our analysis is from this phase, so bear with me. So our demographic characteristics, for the IDI and FGD, we interviewed 27 diabetes educators. Most of them were female, aged between 31 to 40, and most of them were nurses. We ensured during the interview we covered all levels of seniority, years of service. So we have the senior, more than 8 years, in between 3 to 7, and junior, less than 2 years. And we ensured that all clinic types were present for the interviews. So repeated message that we encountered during our analysis was how the DEs had persevere and keep holding on despite the barriers that they face. 3 main themes emerged from our analysis, which were personal, patient, and organizational factor. Within these three themes, there were also sub-themes that I will explain in next slides. Okay. For the personal factor, there were 4 sub-themes, and these are the categories within each sub-theme, but I will not explain each and everything. I will highlight the most important ones. So in personal factor, mostly they were facilitators. For example, one of the motivating factor for them was they had this intrinsic duty, rasa macam fardu kifayah lah, obligation to help the community in controlling the diabetes, like this verbatim here, niat lebih kepada membantu masyarakat. And then another motivating factor for them was the improved patient's health, and also when the patient expressed gratitude for the care received. And another facilitating factor for them was the skills that they acquired to engage with the patient, such as the soft skills. It helps them. And then for the patient factors, there were 3 sub-themes, and these are the categories within each sub-theme. So for patients' needs and preferences, one of the barriers mentioned was like in a rural area in Negeri Sembilan, the patient expected the nurses to do home visit, and they were persistent about the home visit. So the DEs had to go there, and this takes their time away from the clinic. And for under patients' understanding and acceptance, it is a facilitating factor if the patient follow the advice and practice what they learn. But on the contrary, there were also some patients who were resistant to the advice given despite many counselings given. And I want to highlight here about the patient's clinic attendances. There were instances where patient did not come for their appointments. So this is a barrier, especially warga emas, usually because of transport. Because when the patient did not come for their appointment, this steals the time away from other patients waiting for an appointment. Okay, moving on to the biggest factor. We had six sub-teams in this organizational factor team and lots of categories, but I will only highlight the more important ones. For workload, the DEs highlighted that they were multitasking. They had to do multiple procedures at the same time. That's why they find it no time to do the DE work. They had to prioritize other things first. And for staffing resources, the DEs highlighted that although the number of patients keep increasing substantially like this, but the number of staff is not parallel with the increase. The number of staff was constant. So although they have the knowledge and skill, they could not apply the skill because they had to rush to see the patients. And then on the positive side, when in a clinic, when you have more than one staff and you dah agree awal-awal that you take this and you take this, that is a facilitating factor because that way the DE can focus more on her job. Okay, because of the workload that they face and the KPI that they need to achieve in NCD, they did not have time to do that during working hours. So they had to come during weekends to do filing, to arrange the lab results. And another important barrier that I want to highlight is the heavy amount of documentation highlighted here, such as written NCD, written pre-pregnancy care, the PPC, and census. And some of the clinic did not have fundus camera, so the DE have to bring the patient to the nearby clinic to do the fundus camera. If they did not bring, the patient won't go. And after that, they need to go back to the clinic and refer. So it's a complex process, and it is a big barrier to them. Under leadership support, they frequently mention the strong support they receive from JKN and sister NCD who had background in diabetes education is a big motivating factor and facilitating factor. On the contrary, there were some supervisors who did not understand the role of DE, who assumed the role of DE is just to do written. And there were also supervisors who did not provide emotional support to the DE. And there are some DEs who have ideas to improve their clinic, but supervisors did not facilitate the idea. That's a barrier to them. And sometimes they did not go down to the clinic for supervision. On the plus side, there were also facilitating factor where the supervisor share the load with their subordinate. Usually, for example, this MA who has a background in DE, so he knows and understands the gravity of DE staff. That's why he shares the load with the staff, which is a big facilitating factor for the staff. And then another facilitating factor is the presence of a rather strict doctor who has clear instruction what the DE should do. But on the other side, on the negative side, one of the barrier mentioned was the haphazard work assignment. Usually this work assignment was made by the supervisor, immediate supervisor. Like for this example, every day at different places. So the DE find it difficult to focus and achieve their KPI for NCD. Okay, for career development and pathway, the DEs highlighted that some of the supervisors perceive that if you want to stay in klinik kesihatan, you have to do midwifery. Like this DE wanted to pursue degree in diabetes education but did not get the support because midwifery is seen to take precedence over others. On the positive side, they mentioned about the support that they received from JKN, who always sponsored them to attend workshop either local or internationally to increase their knowledge. Okay, for the teamwork, it is a facilitating factor when all the team members in the clinic have a shared understanding of what DE role is, regardless of their pangkat or hierarchy. But they also highlighted a barrier where there is a lack of coordination between MCH, Maternal and Child Health Unit, and NCD, where, for example, GDM patient, gestational diabetes patient, after 6 weeks, they have to do MGTT. If the result was abnormal, they need to be referred straight away to NCD. But in some instances, this did not happen. And when the patient was finally referred, the disease has progressed. Okay, under clinic management, it is a good facilitating factor if the clinic has a dedicated NCD team and the number consistent throughout the year, the NCD team, and each member in the team has their own job description. This makes the work seamless. On the negative side, the barrier mentioned here is there was a lack of flow or complex referral process in the clinic. So the DEs had to travel from room to room to ask the doctor to refer, which takes their time away from the patients. Okay, under infrastructure, it is a facilitating factor if there is a space, designated space or room for the DEs to counsel patients, to put their teaching aids and to put their fundus camera, not only for the DEs but also this is the patient as well, as they do not have to move so much. And on the negative side, the barrier that they encountered was in some clinic, especially the small clinic, they did not have driver or transport. So the nurses themselves have to go to the nearby lab to collect all the lab investigation, and this usually during the office hour, during the clinic hour. Okay, and then like I mentioned before, under role conflict, the DEs are usually AMO and nurses by profession, so they have other expectation by their supervisors. So sometimes they need to work at the ambulance call at the procedure room. So for this example, this DE, in a week, he only has time one day to do his DE task. So it's not enough for him. For discussion, okay, despite the barriers that they encountered and I've mentioned before, DEs were still able to spend majority of their time for diabetes care, but for documentation rather than the education. And heavy amount of documentation were repeatedly expressed by DEs as barrier to their work. And this is also echoed in several studies on nurses, where the time spent for documentation was actually more than the direct care. Outside of diabetes care, they spend more time on non-NCD patients because usually the role of general nurses and AMO take priority over the role of DE. And also there was lack of supervisors' supervision. When the supervisor did not supervise, this does not help in improving the understanding of DE role in PHC. Okay, an article by Hussein et al. Mentioned that management of PHCs is oriented towards acute care and MCH, and management of chronic diseases, especially diabetes, has not followed the same process and agility. So the DEs also expressed there was an unequal management of NCD and MCH, and this hampers their activities. It was difficult for them to coordinate activities. And on the plus side, for the facilitator, DEs expressed that the patient's appreciation and clinical improvement as their sole motivation. And then the teamwork that they experienced among all HCPs in the clinic were also reported as facilitator in building supportive work culture at their clinic. As also highlighted in other study as well, cooperation and teamwork is an important component to ensure smooth flow of services. So in conclusion, in Negeri Sembilan, what we found, the role of DE is not only about managing diabetes patients, but it extends beyond it. Most of them were able to devote majority of time for diabetes care, and the facilitators help them to achieve this. Thus, the facilitators should be amplified to further strengthen the DE role. In the context of primary care, what we saw, there was the increasing burden of NCD, and it was also mentioned in the interview. But MCH was perceived as to take priority. That's why the DE faced complication and difficulties to proceed in some activities. From our study, we combined quanti and qualitative approach. We explored and also we observed the DEs doing their work. So this provided a thorough view of DE's activities within PHCs. And our study findings provide insight into how they utilize their time in PHCs, and it can serve as valuable evidence to our stakeholders on how to understand and reinforce DE's role. So, our recommendations is in line with the National Strategic Plan for NCD 2016 to 2025. We recommend to raise supervisors' understanding of NCD importance and DE role, and we recommend to raise the number of supervisors with DE background as they understand the gravity of DE's tasks and activities and the importance of NCD. And we recommend to raise dedicated space for counselling, as it not only helps the DE but also the patients. And we recommend to reduce midwifery preference in all aspects, staff allocation, work delegation, and also career progression, and create a recognition by certifying body to uphold the value of DE. For example, in other countries like Canada, Japan, Australia, they have this proper certification body that uphold and recognize the value and importance of DE. And we recommend to create a dedicated NCD team with clear job description, and to eliminate heavy and duplicative documentation, like mentioned from the interviews, and unclear work processes and complex referral process, and finally to eliminate negative work culture. Okay, this is our limitation. Because our study was observation, there was still the possibility of Horton effect. Though efforts were taken to mitigate this, we cannot 100% exclude that it did not happen. And then our observations were for 5 working days in the clinic. From the interview earlier, some of the DEs mentioned that they came during weekend, but unfortunately, our limitation, we were not able to capture this during Saturday and Sunday activities. And the views expressed in the study of the respondents' own opinion and may not be representative of the wider population. So with that, these are our references, and that's all from me. Thank you very much. Back to you, Eliana.
All right. Thank you, Doctor, for your splendid and extensive explanation. Here comes your adrenaline rush. Anyway, right. But before that, just a quick reminder for those who just joined us, do register yourself in the links provided in the description section. And if you want to ask any question, you just type or key in your question also in the link provided in the space in the description section. All right. So we have a little bit of time, so we can open up for Q&A sessions. Right. I have a few questions in the list. The first one is from Ms. Dia Rakmi Uniarti. She asks, what is the suggestion of giving the information and educational understanding of the people who live on the mountainous area, which are sometimes don't know about diabetes illness, and also the kinds of food that contains the diabetics?
Okay, interesting question.
Yes.
Mountainous area, I assume this is from someone who lives in Sabah or Sarawak.
Yes, maybe.
This is a bit of a challenge. I think, I'm not sure about the diabetes educators availability in Sabah or Sarawak and where are they positioned. But understanding that usually in mountainous area, maybe technology tak sampai ke sana kan. So the other role that the DE can do in Sabah Sarawak is at the community clinic. Oh, Indonesia. I'm so sorry, Indonesia.
Wow, we have international audience. Thank you for watching us.
Okay, Indonesia. That's a different country. I'm not sure how the healthcare system in Indonesia is, but in Sabah or Sarawak here, actually the Diabetes Educators Foundation in this Sabah state is quite strong. They have a lot of diabetes educator. From our list of diabetes educator, there was many diabetes educator in Sabah, but I'm not sure where they were stationed. But considering in mountainous area, there is a limitation of technology. So any education via technology may not reach the people in mountainous area. So I think the way to go for those living in mountainous area is community outreach. The staff themselves have to go there, because if you expect the patients to come to the clinic, it may be difficult.
Yes.
So that's the way to go in my opinion, considering the limitation in technology.
Yes, I agree to that. Okay, now second question from Dr. Nurihan binti Jina. She asked, what do you think about study on comparing outcomes of diabetic management with and without involvement of DEs?
Okay, that is an interesting question, an interesting topic to be studied. But in my opinion, to talk about the effects of impact of diabetes educator on patient outcome, first you need to strengthen the DE's role first and ensure that they were able to fully optimize their role and fully optimal time for diabetes care in PHCs. Only then can we accurately measure the impact of DE services to the patients. Because if you have not strengthened the DE role, I think it does not accurately reflect their impact of DE.
Yes.
Because they were not able to provide the intended service at the optimal time.
I hope that answers your question, Dr. Nurihan. Okay, the third question. Wow, this one is from Mr. Iskandar Jujo.
Okay, from which country?
I'm not sure. Do you have the details? Okay. All right. No, sorry, we don't have the details. Sorry. So the question is, in the future, will be volunteers from NGOs or community will be included in public services SDE in health clinic? What do you think about this? Maybe can help to reduce the burden of doing documentations or to, increase direct interaction with patients. Do you think, is it possible to do so?
I think it is a very interesting opinion and suggestion. Although in our Ministry of Health, we have not actually thought about this yet. But considering, because of, we know that in MOH, we have these staff resources, limited staff resources. To increase the number of staff may be difficult in the short term. I'm not sure about the long term. The idea of incorporating NGOs and political party is interesting because it helps the ministry to control the diabetes disease, because we are at a complication where we cannot increase the staff at the moment. So other helps from other parties will benefit us.
I think so.
Yes.
Okay.
It is
so
a
this
good
one
suggestion.
is from next question from Anonymous.
Okay.
She asked, reflecting back on this study, were there any unexpected findings from either phase of this study? Could you share some of the experiences on how this study may be different to your earlier understanding of the issue during the planning part of the study? Did your perception change?
Okay. So, from our earlier planning, we aim to capture and quantify the occurrences of task multitasking and task switching. We wanted to see how many minutes were spent for this. But as it happened, it occurs within fraction of time, within seconds. So we had difficulty in analysing and distinguishing this. So in the future, I think it is good that we can create maybe an all-inclusive tool that were able to capture all these occurrences, and a more sensitive tool so that it better describe the intricacies of DE's work in the PHCs. That is from our point of view, what we experience.
Okay, this is like another question actually from me. I'm putting myself like a Jabatan Netizen Malaysia or keyboard warriors now. Okay, for example, your study scope, your study site is in Negeri Sembilan. Okay, why do you choose Negeri Sembilan? Okay, we Malaysian, we perceive that the eastern coast of states like Kelantan, Terengganu or even Kedah would have a higher number of diabetic patients. But then why did you choose Negeri Sembilan as your study site? Do you have any specific reason for this?
Our choice for Negeri Sembilan is actually based on the data from NHMS findings, which surprisingly Negeri Sembilan recorded the highest prevalence of diabetes in Malaysian adults in 2019. That's the first factor why Negeri Sembilan. And ideally, we would like to do in other states, but because of the financial limitation, it takes a lot of budget to do the time observation. So that's why we chose only one state, and the state chosen was actually based on the NHMS findings, because Negeri Sembilan recorded the highest prevalence of diabetes, and also the cooperation by the JKN themselves.
Okay, so netizen and keyboard warriors, this is the reason. Okay. All right, so because of that, there will be next question.
Okay.
Right. So moving forward, what future research projects that you and your team can think of?
Like I've mentioned, this study is only in one state. So I assume people like you ask,
yes,
why not other state? It's mainly because of financial and limitation.
True.
Because it takes 100,000 to do this
One
study.
state. For one state. Yes.
So if other state, we now open the opportunity for other states to take up this direct observation time motion study, because as we know, there was no study. With this study, we hope that this open up opportunity for other states to replicate this as well, if the NCD in that state is interested. That is the future study that I would recommend, because each state has their own variations and own variables that may differ from Negeri Sembilan. So it is interesting if other states who are interested to replicate this study as well, to capture what are the challenges in their state.
Okay, so another question. Your findings seems to echo with the previous few studies that have been done. So from your findings, did your stakeholders take up your suggestion and recommendation? So what are their countermeasures or action has been taken so far?
Okay. That is still under discussion. We had we already presented to one stakeholder. We will present again.
Did they say that we going to add more staff at the diabetic department?
Their concern was for documentation. They wanted to do something about the documentation
part.
Yes, because about staff, it's a bit difficult at the moment. But what they can do is documentation, because documentation, as you can see, the proportion was highest for patient documentation, and some of the documentation was, as you know, we have so many documentation in the clinic. Maybe we can streamline the documentation. So that's what they want to proceed with first, the documentation and the returns, to streamline the returns so that it won't be so much for the DEs.
Okay. I take note of that. Netizens hear this. All right. So next question. Who can be the diabetic educators? Can we just train all people with at least basic or middle knowledge of healthcare to help with the documentation part, or even to have direct interaction with patients? Who can be, despite from nurses and AMOs?
So far, from our literature in other countries, the diabetes educator is not only the nurses and the AMOs, but it's from medical background lah. Pharmacists, doctors, and physiotherapists usually are the diabetes educators. Usually within the medical background, because they need to have the knowledge of the diabetes disease before they become diabetes educators. Yes. So that's it.
So apart from MO and nurses, the pharmacists can also be trained as the diabetic educator. Okay.
But they need to understand the diabetes knowledge, diabetes.
Do they need to have any specific requirements or legal certificate or whatever to be a diabetic
educator? In our country, they need to pass that post-basic certificate and or advanced. Post-basic certificate is the first module, and that it was upgraded to advanced diploma. So for those who are interested, they need to take up that module, advanced diploma in diabetes care. When they have this qualification, then they are called diabetes educator.
Okay, then you will have a certified diabetic educator certification lah. Alright. So what is your take home message?
Are you interested to become
Are you inviting me to be a diabetic educator? Alright, it's okay. I'm not interested. I'll just stick to whatever I'm doing now. Alright. So what is your take home messages for today?
My take home messages. I think the role of diabetes educator is still undervalued in our country, especially in health clinics. So my take home message.
Do they have any extra incentive when they be the diabetic educators? No.
They had allowed, but to me it's quite okay lah. They had allowed lah. Maybe not up to their hard work, but but they had allowed lah. So my take home message is appreciate your diabetes educator. If you are a diabetes patient, please know that diabetes educator really contribute hard work to manage you, and please appreciate your diabetes educator and follow their advice and help ease their work. That's my take home message, because I really understand the difficulties that the diabetes educator face in PHCs. It's not that they did not want to do their job, but they face many challenges.
So they have so many obstacles.
Yes, they felt frustrated because they cannot apply what they learn. So please help them.
I'm afraid that they will be demotivated one day. Do you think so?
No.
I hope not. I hope not with the incentive that you have.
Yes.
Yes. All right. So that's wrap everything up for today. Thank you all for joining us. Those who has registered, you will receive your certificate within a week after this session. And I hope you enjoy our session today. And lastly, don't forget to subscribe to our YouTube channel and catch us on our latest update. So till then, till we begin. Bye bye.
Okay, bye.